Now let's talk about the home management of asthma. Early treatment by the patient at home is the best strategy for maintaining asthma exacerbations. Patients should be instructed how to 1. Use a written asthma action plan that notes when and how to treat signs of exacerbation. A peak flow based plan may be particularly useful for patients who have difficulty perceiving airflow obstruction or have a history of severe exacerbations. 2. We want to recognize early indicators of an exacerbation, including worsening PEF. Adjust their medications, number 3, by increasing SABA and in some cases adding a short course of oral systemic corticosteroids. Doubling the dose of ICSs is not effective. 4. Remove or withdraw from allergens or irritants in the environment that may contribute to the exacerbation. 5. Monitor response to treatment and promptly communicate with the clinician about any serious deterioration in symptoms or PEF or about decreased responsiveness to SABA treatment, including decreased duration of effect. The following home management techniques are not recommended because no studies demonstrate their effectiveness and they may delay patients from obtaining necessary care. Drinking large volumes of liquids, breathing warm, moist air, or using over-the-counter products such as antihistamines or cold remedies. Pursed lip and other forms of breathing may help to maintain calm, but these methods do not improve lung function. Let's talk now about the management in the urgent or emergency care and hospital settings. Emergency medical service providers should have pre-hospital protocols that allow administration of SABA, supplemental oxygen, and anticholinergics and oral systemic corticosteroids to patients who have signs or symptoms of an asthma exacerbation. Treatment strategies for managing moderate or severe exacerbations in the urgent or emergency care setting are described as below. So we want to administer supplemental oxygen to correct significant hypoxemia in moderate or severe exacerbations. We want to administer repetitive or continuant administration of SABA to reverse airflow obstruction rapidly. Administer oral systemic corticosteroids to decrease airway inflammation in moderate or severe exacerbations for patients who fail to respond promptly and completely to SABA treatment. Monitor response to therapy with serial assessments. So for children, no single measure is best for assessing severity or predicting hospital admission. Lung function measures, FEV1 or PEF, may be useful for children greater than 5 years of age, but these measures may not be obtainable during an exacerbation. Pulse oximetry may be useful for assessing the initial severity. A repeated measure of pulse oximetry of less than 92 to 94% after 1 hour is predictive of the need for hospitalization. Signs and symptom scores may be helpful. Children who have signs and symptoms after 1 to 2 hours of initial treatment and who continue to meet the criteria for a moderate or severe exacerbation have a greater than 84% chance of requiring hospitalization. For adults, repeated lung function measures, or PEF, at 1 hour and beyond are the strongest single predictor of hospitalization. Such measures may not be helpful or easily obtained during severe exacerbations. Pulse oximetry is indicated for patients who are in severe distress, have FEV1 or PEF less than 40% predicted, or are unable to perform lung function measures. Only repeat assessments after initial treatment, not a single assessment upon admission, are useful for predicting the need for hospitalization. Signs and symptom scores at 1 hour after initial treatments improve the ability to predict the need for hospitalization. The presence of drowsiness is a useful predictor for impending respiratory failure and is the reason to consider immediate transfer to a facility equipped to offer ventilatory support. So we want to consider adjunctive treatments such as intravenous magnesium sulfate or Heliox in severe exacerbations if patients are unresponsive to the initial treatments listed above. FEV1 or PEF less than 40% predicted or personal best offer initial treatments. We want to provide the following to prevent the relapse of exacerbation and recurrence of another exacerbation. We want a referral to follow-up asthma care within 1 to 4 weeks. In addition, encourage the patient to contact by telephone, or however they choose, his or her asthma care provider during the first 3 to 5 days after discharge. A follow-up visit is essential to review the patient's written asthma action plan, adherence, and environmental control to consider a step-up in therapy. If appropriate, consider a referral to an asthma self-management education program. An ED asthma discharge plan is something that's in great need. Review of an inhaler technique whenever possible. Consideration of initiating ICS. And treatments that are not recommended in the emergency care or hospital setting include methylxanthines, antibiotic, except as needed for comorbid conditions, aggressive hydration, chest physical therapy, mucolytics or sedation. Inhaled ipratropium bromide is helpful adjunctive therapy in the emergency care setting, but does not provide additional benefit after a patient's hospitalized for a severe exacerbation. So now let's talk about a differential diagnosis of asthma. A differential diagnosis of asthma should be considered. Recurrent episodes of cough and wheezing most often are due to asthma in both children and adults. However, other significant causes of airway obstruction leading to wheeze must be considered both in the initial diagnosis and if there is no clear response to initial therapy. Additional studies are not routinely necessary but may be useful when considering alternative diagnoses. Additional pulmonary function studies will help if there are questions about COPD, the diffusing capacity, a restrictive defect, measures of lung volume, or BCD, evaluation of the inspiratory flow volume loops. Bronchoprovocation with methylcholine, histamine, cold air, or exercise challenge may be useful when asthma is suspected and spirometry is normal or near normal. For safety reasons, bronchoprovocation should be carried out only by a trained individual. A positive test is diagnostic for airway hyperresponsiveness, which is a characteristic feature of asthma but can also be present in other conditions. Thus, a positive test is consistent with asthma, but a negative test may be more helpful to rule out asthma. We want to get a chest x-ray. A chest x-ray may be needed to exclude other diagnoses. Biomarkers of inflammation are currently being evaluated for their usefulness in the diagnosis and assessment of asthma. Biomarkers include total and differential cell count and mediator assays in sputum, blood, urine, and exhaled air. Common diagnostic challenges include the following. A cough variant asthma. Cough can be the principal or only manifestation of asthma, especially in young children. Monitoring of PEF or bronchoprovocation may be helpful. Diagnosis is confirmed by a positive response to asthma medication. VCD can mimic asthma, but it's a distinct disorder. VCD may coexist with asthma. Asthma medications typically do little, if anything, to relieve VCD symptoms. Variable flattening of the inspiratory flow loop on spirometry is strongly suggestive of VCD. Diagnosis of VCD is from indirect or direct vocal cord visualization during an episode, during which the abnormal adduction can be documented. VCD should be considered in difficult to treat atypical asthma patients and in elite athletes who have exercise-related breathlessness unresponsive to asthma medication. So, gastroesophageal reflux disease, often known as GERD, obstructive sleep apnea, and allergic bronchopulmonary aspergillosis may coexist with asthma and complicate diagnosis. So, children 0 to 4 years. We want to diagnose in infants and young children is challenging and is complicated by the difficulty in obtaining objective measurements of lung function in this age group. Caution is needed to avoid giving young children inappropriate prolonged asthma therapy. However, it's important to avoid underdiagnosing asthma and thereby missing the opportunity to treat a child by using such labels as wheezy bronchitis, recurrent pneumonia, or reactive airway disease. The chronic airway inflammatory response and structural challenges that are characteristic of asthma can develop in the preschool years, and appropriate asthma treatment will reduce comorbidity. So consider referral to an asthma specialist if signs and symptoms are atypical, if there's problems with the differential diagnosis, or if additional testing is indicated.